Hi guys, so we're going to talk about the somatic disorders and specifically about somatic symptom disorder, illness anxiety disorder, and then conversion or functional neurological symptom disorder. But we'll start with somatic symptom disorder. And first of all, it's important to know that in the DSM-5, we've changed some of the terminology that we use for these disorders, and that the change is important in some ways. So we don't use terms anymore like hypochondriasis, and we don't assume that a person does or doesn't have symptoms per se. It's just about how they're managing their experience of their physical symptoms. So in somatic symptom disorder, somatic symptoms, right, are physical symptoms, soma meaning body, and so the person actually has somatic symptoms. They actually have physical symptoms of some kind. We don't need to worry ourselves with where they're coming from, whether they're actually physically caused or psychologically caused, but it's clear that they're experiencing an actual symptom. They're complaining of pain, they're complaining of headache, they're complaining of of something like that. And they're feeling very distressed about this, and they're engaging in rumination or lots of excessive thinking about it, behaving in certain ways around it. And the idea here is that the person's concern is exceeding what we consider social norms for reactions to that symptom. So it's not about the symptom itself and whether it's real or not real, it's about the person's reaction. So they're saying that they're having back pain, or they're saying that they're having digestive problems, and their preoccupation with it exceeds what we would expect the preoccupation to be. And this has to be going on for at least 6 months. Um, so so I always think here of a patient I had in the past who had actual diagnoses from medical doctors. She had had a heart attack unexpectedly in her late 30s, I think, out of nowhere. She had fibromyalgia, and had clear problems undiagnosed with digestive issues. So she had real symptoms, and real doctors were seeing those symptoms and seeing the problems causing the symptoms as significant. However, her reaction to them was disproportionate. And so she, in the time that I knew her, had gone out on short-term disability several times because of fatigue. She, ever since her heart attack, had spent every weekend just lying on the couch and feeling like she couldn't or shouldn't do anything. And so she really wasn't living her life in many ways, even though her doctors thought that her symptoms were real and concerning, but not life-ending or life-altering in the way that she did. And so that's a nice example of somatic symptom disorder. Her preoccupation and reaction to the symptoms just exceeded what one would expect. And so if we look real quick here, there we go. At the criteria of somatic symptom disorder, you can see that it's one or more somatic symptoms, right? Distressing or results in significant disruption of daily life. So disproportionate persistent thoughts, persistent levels of high anxiety, excessive time and energy devoted to the symptoms or health concerns, right? And again, we're not saying whether the health concerns are real, and in many cases they are real. We're just talking about what the reaction to the symptoms are. So that's somatic symptom disorder. Illness anxiety disorder is what we used to call hypochondriasis. We don't anymore. Hypochondriasis became kind of tainted with bad connotations and dismissive connotations. Illness anxiety disorder is about a preoccupation or fear of having a serious illness. And so this fear continues despite the absence of symptoms and reassurances from medical professionals that whatever they're concerned about is not real. And so often this results for some people in doctor shopping because they are so convinced something is wrong that when a doctor tells them they're fine, instead of greeting that with relief, they go to the next doctor who might tell them otherwise. And again, this reminds me of a client who, in the first 3 months that I knew her, was concerned that she had ovarian cancer, uterine cancer, was afraid that she had developed MS, multiple sclerosis, was afraid that oh, I'm forgetting what else. She thought she had a brain tumor at one point, right? And all of these things caused her real anxiety and real distress. It's very easy to feel dismissive of this, very easy to hear these stories and to find them kind of funny in some way. But for the people experiencing it, sorry about that, guys, a little coughing fit. For the person experiencing it, it's actually a very troubling disorder and creates a lot of discomfort in their life. What is used to be called conversion disorder, and now I'm going to pull out and go back out to the criteria that I want to take a look at. Conversion disorder is now called functional neurological symptom disorder. And so one of the important distinctions here is that this is only for neurological symptoms. And so it has some overlap, certainly with somatic symptom and illness anxiety disorder. But it's only for neurological symptoms. So it's about voluntary motor or sensory, so either the ability to move or the ability to have sensation. So often this is symptoms like numbness or paralysis. Um, what medical findings are going to find that the symptoms themselves are incompatible with how we know the motor and neurological systems function. So, for example, having a glove anesthesia, where you only lose sensation from the wrist on, like or from here on, where a glove, right, from here on where a glove would cover, is not neurologically possible. And yet the person is reporting that that's what they're having. And so that would often be the first sign of it, that's maybe what's going on. And so conversion disorders, these sudden neurological symptoms that have no confirming medical tests. The person, again, that la belle indifference, the person is often undisturbed by their symptoms, but it's not factitious disorder. They're just, remember that these symptoms are serving a purpose as a coping mechanism, and so that's part of the lack of distress. And really, this is a very psychoanalytic idea. Freud wrote a lot about conversion disorder in his original writings. It was a much more common disorder in Victorian Europe than it is now, though interestingly, it continues to occur at higher rates in more repressed societies. So if we look at societies where that are less open, where there are more rigid rules for behavior, and especially more rigid rules around sexual behavior or sexual discussion, we see more conversion disorder. So essentially where people are less able to emotionally express themselves, we see higher levels of conversion disorder. When we look at the etiology of somatic symptom disorder, all of these, we do find that the brain areas involved in evaluating body signals are hyperactive, meaning that your brain is working harder to make sense of body signals, which may wind up with false positives, right? With a brain that's misinterpreting some signals. And our somatosensory cortex, right, our parietal lobe back here, is more active overall. And so, right, so that's consistent with what we said before. Large, high levels of co-occurrence with depression and anxiety here. And we know that depression and anxiety can affect how those brain areas function. So the assumption here in terms of etiology from a cognitive behavioral point of view is that the person has been reinforced for this behavior in some way, either reinforced by the attention of doctors, by the attention of family members, or by avoiding their own anxiety by focusing on the physical symptoms instead, or getting out of task or responsibility. And so my first patient that I mentioned who had the cardiac history, is a good example here that she actually got out of many obligations with her husband, including sexual obligations, because of her preoccupation and concern about her physical symptoms, and in fact, got out of a lot of work things as well, and so there had been a lot of reinforcement for that. And so it's not that it necessarily starts with that, but that it ends with that. The other thing, so for my second patient that I talked about is that she also had a family history in which her mother had had lots of physical problems when she was growing up. I have no way of knowing whether those were real medical diagnoses or related to psychiatric issues. But either way, her mother was pampered by her father for having had those complaints, and so, right, some vicarious reinforcement for that as well. If we look at psychoanalytic etiology, we kind of have talked about this as we've gone along. It's about a coping mechanism, it's about a defense mechanism, and it's about unconscious process. And so if we're going to treat these, then we're going to take both of those pieces of information. A lot of the treatment is going to focus on insight-oriented therapy from a psychoanalytic point of view, or, and I would say probably more often combined with, looking at patterns of reinforcement and making sense of those in terms of, kind of what is sustaining or has been sustaining this behavior in other ways. And because of its overlap with depression and anxiety, we're going to see relatively high uses of SSRIs here as well. And so, in that way, it's going to look very much like the preceding disorders. So we're going to stop there. Make sure that you read the case studies in class 2 because we're going to talk about those in our live discussion.